What I'll talk about today about home dialysis, I'll talk about the clinical implications and economic implications. I'll try to convince you that probably the peritoneal dialysis should come first. And this is a view which I hold based on data and experience. And I'm sure the data supports very much that PD should be given the first chance before hemodialysis. And second consideration or implication, I'll talk about the economic complication. And we know that everybody is very concerned about how much this costs and how much at the end the Ministry of Health will pay as for the treatment. Professor McLeod, he said that patient whose kidney failure requires life-saving treatment with dialysis or with kidney transplant. This is really a reality. He said, although dialysis is now very advanced, allowing more patients to be treated successfully, it's also very expensive. And this is really absolutely correct. It's essential, therefore, to ensure that resources are used as effectively as possible. Why PD should come first? PD should come first for various reasons, and I'll try to touch upon each point of this very short note. That first of all, that when we start peritoneal dialysis first, I mean first means when the patient ends end-stage renal disease, the first stage is not hemo, it's PD. Why should you start PD first? Because there is better preservation of residual renal function. Number two, there is data showing that there is initial survival advantage of PD than hemodialysis. Number three, we know that the problem we are facing with vascular access, and we will tend to preserve the vascular access. And four, hepatitis C is very rampant and common in this part of the world, and by resorting to peritoneal dialysis, we'll be probably able to prevent hepatitis C transmission to our patient population. And there is some data showing there's better graft and survival and less delayed graft function. And certainly everybody talks about quality of life, and I'll show you some data about quality of life and about logistics. First of all, why BD first? First, better preservation of residual function. You know that the kidney actually has many functions besides the excretion of the waste products. It's provide endocrine functions, and we know about erythropoietin. It reduces mortality. The moment you have residual renal function, the meaning of residual renal function means that the urine you have to pass, even if you have end-stage renal disease. And actually this little amount of urine which you pass, okay, for the patient with end-stage renal disease, it's improved quality of life. It's increased total salt removal, improves nutritional status, allows for more liberal diet and fluid intake, and certainly it's improved beta-2 microglobulin excretion. And actually there's so many studies showed that it really contributes to total solid clearance, and each 1 ml per minute of creatinine clearance equals 10 liters of creatinine clearance per week of dialysis. This is the data actually from GSN 2000 showing that what are the risk factor of loss of residual renal functions in patients who start on dialysis. And number one factor is hemodialysis. This means that if you start your patient on hemodialysis, there's very good likelihood that they will lose the residual function within the next 6 months. This actually another study by the old study in Science Journal showing that actually CEBD tend to preserve RRF better than hemodialysis, and it's actually a third study published 2001 showing CEBD patients have better preservation of residual renal function compared to hemodialysis. So certainly we've shown actually this data, and there's actually other data of which NICOSAD study showing that residual GFR is better maintained in incident peritoneal dialysis patient than in incident hemodialysis patient. So you tend to preserve your RRF with peritoneal dialysis. And actually they calculated that the relative risk of death for each 1 ml per minute per 1.73 square meter was 0.9. This means 10% less after adjustment for other factors. This means that if you have 1 ml of urine per minute per 1.73 square meter urine, even with end-stage disease, you have reduced mortality by 10%. So that RRF is very essential to maintain and to keep, and the only modality which keep that RRF is peritoneal dialysis. Number two, why PD should come first? Because there is actually data showing that initial survival advantage. If you look at the Danish data here, this is the hemodialysis patient. Until 2 years, they have higher mortality than peritoneal dialysis. After that, of course, they will equalize, and after 4 years, PD mortality will go up. So why not utilize PD in the first 2.5 years, or even 3 years of starting interstitial disease? That's actually the best time for reduced morbidity and mortality. Then why should we start peritoneal first preservation of vascular access? Everybody has lots of stories about how access is a problem in our patient population. I have few points to ask you to remember and things to remember. We have to remember that end-stage disease is lifelong ordeal, even if we transplant them. Okay, one day they will be CKD. Actually, they are CKD patient, and one day they will be approaching end stage again. 5 years, 10 years, 25 years, 30 years. Certainly, if they survive, they will. So it's a lifelong ordeal, and we have the access problem. We have to think about access problem for our patient all the time. Keep the access issues in front of your eyes when you define any kind of treatment. We know that our end-stage diseases have higher morbidity and mortality, irrespective of what we do, even if we transplant them. We have to think about the survival lines for our CKD patient. Instead, we have one PD membrane, one peritoneal membrane. Either use it or lose it. You have 4 sites for permanent vascular access. You have 2 ILX for transplantation. So that are the lifelines for our patients. And we have to think about how we utilize them best and what sequence we use them. We have to know that the creation and maintenance of adequate vascular access remains a major problem in hemodialysis. Everybody talks about this one. And everybody is complaining that we are not achieving much in nephrology because of vascular access. So that any strategy which can augment the total lifespan of vascular access is of great value. And additional time is won by starting PD, because that PD membrane, if you start hemodialysis, you lose RRF, and you lose that membrane with time. So if you want to utilize that membrane first. Start PD first for 3 years, then transplant your patients, or if the complication arises, go for hemodialysis. But if you lose that membrane, you lose it forever. This is one of my patients who had actually SVC obstruction, and I have tons of those patients. It's not my patient, they're coming to me as referral. And we have actually in our center at least 45 patients. We have done transhepatic dialysis because they refer to us from everywhere, and there is no access. And the only survival line is just to a transhepatic catheter. And you know that the mortality is high, eventually they will die. So, and this patient, one of them died. This is actually the last patient I've seen this week, Sunday, in my clinic, where she has actually venous hypertension in her hand, where her hand is quite swollen and with severe pain, and the only thing is just to go for angioplasty. So this means that it's really a problem. And this actual study of Metcalf showed that the prospective study of 500 patients starting dialysis, that the most common single reason for admission to hospital was creation of vascular access for hemodialysis or the complication. And the use of temporary access associated with increased morbidity and infection. And patients started initially with hemodialysis rather than PD, stays longer in hospital and have more and more problems. It's really clear that hemodialysis is associated with problem with vascular access. Other issue, why should we start PD first? Risk of hepatitis C. Hepatitis C is highest with hemodialysis, especially in this part of the world, means Saudi Arabia and Egypt. This actually study showing how low is hepatitis C in the world. But for the Caribbean country, about 80%. Saudi Arabia up to 40%. And I'm not sure about Egypt, probably 70, 60%. So, correct me if I am wrong. And Asia sometimes can go up to 70%. And if you look at this study by Pereira, showing that patients who are on hemodialysis, they are higher hepatitis C compared to patients on peritoneal dialysis. And even the patients who have hepatitis C on peritoneal dialysis, because before that they were on hemodialysis. So certainly hemodialysis contributes significantly to transmission of hepatitis C. What about transplantation? Transplantation, there is data showing better graft survival and less delayed graft function if you start PD first than hemodialysis due to hemodynamic factors. And it's one of the study which showed beyond doubt that time of onset of graft for hemodialysis is delayed compared to peritoneal dialysis, and even 5-year graft survival is much better for peritoneal dialysis and hemodialysis. There's another study showing the PD having 24%, that's old study, of DGF compared to hemodialysis, and even better graft survival, and even the DGF stays for longer in hemodialysis population compared to peritoneal dialysis. So certainly less DGF and shorter time to recovery, and even better graft survival. What about quality of life? Quality of life is really an issue. The study of Robert Jama showing that at least 82% of the patient compared to 56 in hemodialysis, stating that dialysis is much better, PD, and nothing can be done better. So the data here and here show nothing can be added, nothing can be better. Excellent quality of life has been reported in significantly high proportion of patients on peritoneal dialysis compared to hemodialysis. And if you look at the employment as a sign of quality of life, more patients in peritoneal dialysis are employed compared to hemodialysis, and at least 6 studies which has been published in the literature. So certainly employment is much better with peritoneal dialysis than with hemodialysis. What about the logistic of peritoneal dialysis versus hemodialysis? If you look at we have never-ending story of opening new centers. And this is Saudi Arabia actually. You look at from 71 until 2007, we have almost right now 210 centers, okay, of hemodialysis. So we are just keep increasing our center more and more, and we are not solving the problem. And if you look at how much does it cost us for peritoneal PD and co, if I in my unit in the King Faisal Special Hospital, I have 100 patients for hemodialysis, I have 40 nurses, okay, for hemodialysis. So for hemodialysis patient, we have 100 patients, I have 40 nurses. Take into consideration everything. We does 1 nurse to 2 patients. And for peritoneal dialysis, you have 4 nurses for 100 patients. So each nurse cater for 24 patients. And this age, where we have no nurses and difficult to get nurses, probably the way is to go for peritoneal dialysis. This is very significant saving. And I'll show you some data regarding this issue. So you save the salary of 36 patients, nurses, by just only shifting from hemodialysis to peritoneal dialysis. If you look at the typical labor required for hemodialysis and peritoneal dialysis, this is the hemodialysis. You need 1 consultant nephrologist, junior nephrologist, 2 other staff nephrologists. You have a full-time nurse, 1 full-time nurse per 4 patients. That's actually regional standard, which is Saudi Arabia and Ministry of Health. But actually, if you look at our hospital, 1 nurse to 2 patients for hemodialysis. If you look at peritoneal dialysis, you need 1 nephrologist for each 200 patients. 1 nephrologist. And 1 dedicated nurse for each 25 nurses. And actually ask about Mexico. They told me there is 1 nurse for each 100 patients. So there is significant saving actually when you look at peritoneal dialysis. Now we'll talk about the economic complications. I know I still have 13 minutes, but I'll finish before that time. And about the economic complications of peritoneal dialysis. If you look at actually this study, which showing how much this costs in-center hemodialysis compared to CABD expenses, and the ratio, actually look at Hong Kong, it costs 2.6 times for hemo compared to PD. Actually, they are more advanced with PD there. Similar in New Zealand. The lowest country is Philippines. Even they pay more for hemo than pay for peritoneal dialysis. Mexico here, where is Mexico? The hemo costs 1.4. We're the best country in doing for peritoneal dialysis. Hemo actually costs more than peritoneal dialysis. I remember asking one of my professors in Canada I work with for peritoneal dialysis. We had a very large peritoneal dialysis unit where there's 240 patients. I asked him, which is cheaper, peritoneal or hemo? He said, I don't have the figure, but I can tell you at least PD, if you take it, 30% cheaper than hemodialysis. And actually, this is actually schematic representation of RRT cost. If you look at hemodialysis here, for example, hemodialysis, you find here that there is some transportation issue, hospitalization, pharmaceutical like erythropoietin and others, equipment cost, machines, depreciation, disposables, labor, water treatment, infrastructure. In BD again, you don't have actually, you have transport system. Okay, certainly the company right now providing this, but not to the patient, providing to the supplier itself. Hospitalization actually much lower in BD compared to hemodialysis. Much lower. Pharmaceuticals, there is data showing that actually the ABO consumption is less for peritoneal dialysis. Equipment costs certainly less, disposable, and at the end actually, a label certainly that you have at least 35% or 30% saving. There's actually a study from various countries. The Spain, for example, if you compare here in Spain, hemodialysis or hemodiafiltration compared to CABD, actually almost 40-45% in Spain, PD is cheaper than hemodialysis. If you look at the United States, about 25% cheaper. If you look at for Saudi Arabia, we did study actually through one of the third-party person who is really expert in pharmacoeconomics and other things, and they found actually Saudi Arabia, because the cost of the solution is really expensive. That's about 5 years ago or so. Cost of solution is really cost come imported from UK. We found that only we save about 20% only in the cost of hemodialysis. But right now, for the last years, the factory for manufacturing CABD solution is available in Saudi Arabia. The same in British company, which is, well, not it's Baxter, but UK branch. They are making the factory in Saudi Arabia, and the cost of the supply start to become less and less. So certainly you will save at least 30-35% in your budget allocated for dialysis if you start with peritoneal dialysis. And actually, it's actually another thing which showed actually how much cost for hemopD. That total cost for hemodialysis about $23,000, for PD about $20,000, so almost $3,000 at best, at worst case scenario. And actually, you avoid some costs because actually after years, if you look at those costs, you can save up to $44,000 after 10 years for each patient, dollars. So it's really significant. If you think about survival of a patient with dialysis for 10 years, you are actually ending for each patient saving at least $45,000 for if you put it on peritoneal dialysis. Again, hepatitis C is really common in our area, and actually it costs more. And if you look at, for example, hepatitis C here, hepatitis C cost avoidance, if you just try to target here is about here, and hepatitis C treatment cost here, so you actually save that much in terms of cost if you just try to go to peritoneal dialysis. And the cost actually, when you look at 10 years for that number of patients, about $2.5 million in that study. Again, within pharmaceuticals, APO costs, they have been estimated that you save up to $15,000 after 10 years for each patient. Again, for blood pressure medications and other, for calcium, phosphate binders and other, you save up to $37,000. After 10 years, probably you save up to $44,000. So it ends at the end actually, maybe it's not that much for nephrologists to think about it, but for healthcare policy maker, when they calculate issues at the end and think how much they spend, it really significant. Even if you save about 30% on the cost of dialysis, at the end, you, though 30%, you tend to dialyze more and more patients with that cost. I can tell you that, look at, that's 2001. In Saudi Arabia, actually, we used to have actually only 3% of our patient population are on peritoneal dialysis, and 96% on hemodialysis. And what we did, we showed this data, which I showed to you, to the Ministry of Health personnel, and they show that data and they become very convinced. So they agree to put more and more patients with them, and look at, for example, not that it's 2010. Actually, we have almost 10% of our patients on peritoneal. And the last data we have 13% of our dialysis population in Saudi Arabia on peritoneal dialysis. So we moved from 3% to 13%. When we convince the healthcare policymaker that this is the way to go. The consideration for selection for RRT, selection for RRT usually to optimize the use of each treatment, and I'll show you that why to do it. The factor affecting the choice of dialysis, patient's clinical requirement, certainly, referral time. If the patient referred late, of course, you want temporary vascular access and start hemodialysis. Choice of modality, physician influence. That's what I'm talking about. Actually, we physicians are the worst advocate for our patients. We tend to tell them hemo is better for you. But based on what? Based on data? No. But just based because the circumstances you have around you. So if you give the patient choice and there is data showing that if you give the patient a choice, they will choose PD. So what's the solution for this problem is the integrated care approach. This means that you have to have timely care of the patient, timely preparation, timely education and initiation, and then you manage therapy and switch them from one to one. And what matters at the end is the total survival of the patient, quality of life. Modalities of RRT are complementary. As I said, Dr. Yassin this morning, that is not competitive. We have to look at this morbidity. And I can tell you about this story of Van Beason, showing what patients want to know is which sequence of renal replacement therapy will increase their survival as long as possible, this with the best quality of life. And this is by PD first, and with complication go for hemo, and put the transplantation program. I will not go to study, but this actually, if you apply this integrated care approach, has been shown if you start peritoneal dialysis first than hemodialysis, you have better survival than hemo from the beginning. There's another study from Italy showing that if you started BD first, you have better patient survival than start hemodialysis. I will not go into these studies, but integrated care approach means that at the time of starting dialysis, when the patient has residual renal function, it's better to start peritoneal dialysis for 2 to 3 years. And when the transplantation become available, transplant them. And when there is complication, go for hemodialysis. But start with peritoneal dialysis better, because better and less costly. What Norbert Lanier said, and this is the message of this presentation, said, start renal replacement therapy in end-stage disease patient with BD first. Transfer them to hemodialysis when problems with BD occur, and transplant them when the possibility exists. And in conclusion, I would rather say that BD should be used first as associated with preservation of residual renal function. There is initial survival advantage. There is preservation of vascular access. There is avoidance of hepatitis C transmission, and there is better transplant outcome. BD is a solution to overcrowded dialysis unit, because it will take off this one. BD is a solution for shortage of trained nephrologists and nurses. Estimated that BD is at least 30% cheaper than hemodialysis. And the way to take care of end-stage is by integrated care approach, where you start BD first and then put them in transplant list, and when there is complication, go for hemodialysis. Thank you very much.